Anatomy there, just make sure if you need a refresher, you go into the slides that are posted on the card or this slide, just a refresher so that if you need it, it will help you understand the physiology of the liver, and also somewhat help you understand the testing, the diagnostic testing, including labs and procedures related to the liver and the gallbladder and pancreas. And knowing the tests and the anatomy is really essential because many of these liver diseases just present as abnormal labs initially, so then understanding the anatomy can lead you down the right road for making your differentials and ultimately you're working and getting to the root of whatever the patient's liver problem may be. Once again, just a quick anatomy refresher there of the liver and its blood flow, venous and arterial, and then the venous and arterial flow into the gallbladder. Just a quick refresher on how the blood supply works for the liver. This should all be a review for you. If it's not, and you need to bone up on your A&P and physiology, then please do so, because it will definitely help you understand as we talk about, especially the procedures that we do to look for the etiology of liver and gallbladder and pancreatic diseases. Liver functions, like I said, it's a multitude of things that our liver does. There's a giant list for you there. But basically numerous metabolic functions, right? Carbohydrates are metabolized in the liver, lipids, proteins are synthesized there. We also detoxify drugs and toxins. The liver produces bile. And then it also stores vitamins and nutrients. And we also have some phagocytosis that takes place in the liver. What's phagocytosis? To remember back, that's cellular. Like basically, yeah, cellular eating, like foreign particle, cells eat it, engulf it, and then break it down. And we also have hormone metabolism, takes place in the liver, and activation of vitamin D. So when we look at that list, any issue with one of those bullets, one of those metabolic functions in our bodies, can cause problems with the liver, or problems with the liver itself, or the bile flow between the liver and the gallbladder can affect those processes. So basically, today is all about hunting down what is the cause based on the signs, symptoms, and the lab values. The liver makes bile about 800 to 1,000 milliliters every day. And what does bile do? Yep, fat digestion and absorption. So main thing to know, pretty simple, right? Liver makes it, and where is it stored? Gallbladder, right? Liver makes it, sends it out through the bile duct into the gallbladder. Bile is yellow or brownish, olive green. Becomes important when we talk about disease processes, especially when we talk about jaundice and the different types of bile or bilirubin that are causing the jaundice, whether it be prehepatic or it's formed from actual processes going on in the liver or posthepatic. So stored and concentrated in the gallbladder and aids in dispersion and digestion of fat. Bile functions. So bilirubin is the principal pigment of bile. Bilirubin is made from the breakdown of red blood cells. So mainly macrophages in the spleen, the liver, and bone marrow perform the function of breaking down these aged red blood cells. And it's the bilirubin is a byproduct of heme metabolism. So it actually, bilirubin, I would say, if not one of the most important laboratory markers of liver function is bilirubin. So as the slide said, phagocytosis of red blood cells, they release the iron and globin that is recycled with the bilirubin. Bilirubin gets secreted in the bile from the liver. And then, as I mentioned, bilirubin becomes a measure of liver function. And now we're going to get in-depth into conjugated versus unconjugated bilirubin. So, 4 main steps of the bilirubin pathway. Let's just go through each of those. So, as I mentioned, red blood cells are broken down, and then they're going to release bilirubin. Then in the bloodstream, the bilirubin is going to bind with albumin. Then go to the liver to be conjugated. And then it becomes conjugated bilirubin. Conjugated bilirubin enters the bile, goes to the gallbladder, and the intestine. So big difference between conjugated and unconjugated if it's pre-liver or post-liver. So when the red blood cells are broken down, as it says on your slide, and bilirubin is deposited in the bloodstream from hemoglobin, at this point is still free or pre-hepatic. Then the bilirubin in the blood binds to protein, albumin, and it goes into the liver. At this point, the bilirubin is not water soluble. It's insoluble. Indirect is another term you hear from bilirubin that hasn't been conjugated by the liver. Hepatic bilirubin or unconjugated. Mostly we'll call it unconjugated, but you will see it referred to all 3 ways: indirect, hepatic, or unconjugated before the liver conjugates bilirubin. And once it's in the liver, now it's going to become water soluble when it undergoes conjugation with glucuronide. So the glucuronide, you don't need to know what it is, but just know that it acts in that process. It's a compound that attaches to molecules and forms metabolic pathway basically to take fat-soluble components and make them water-soluble. The main thing you need to know about bullet 3 there is that the bilirubin becomes water-soluble by conjugation with glucuronide. And now it has a new name, 3 new names. We can refer to it as direct, post-hepatic, or conjugated. So once it's conjugated, now it's water soluble, and it's going to be transported to the bile ducts and then into the intestines. Once in the intestines, what happens to bilirubin is bacterial enzymes go to play, and they convert it to several compounds. We won't need to know all of those except for in later lectures. We'll talk some specifics. But collectively, after the conjugated bilirubin is transported and then it gets into the intestines, we're just going to call all of those compounds urobilinogen. So everybody's clear, right? How the bilirubin is formed, the steps of making it, and when it's fat-soluble, unconjugated, in the bloodstream, goes into the liver, gets conjugated, now it's water-soluble, goes out into the gallbladder through the cystic duct, bile duct, and then gets into the intestines, and then once it's in the intestines, it's then further metabolized, and it becomes collectively urobilinogen. So those steps are important because when we start talking lab values and bilirubin and signs and symptoms, we have to make those buckets, right? Is this disease process due to unconjugated bilirubin? Is it due to conjugated bilirubin? Is that what we're seeing as a sign and symptom? Or is it both? Meaning, we got a couple of different issues going on where we're getting bilirubin increasing before the liver and after the liver. All right. So liver function tests. As I mentioned, you'll hear it called liver function test. That's what we're going to order when you get into your charting system, start ordering your labs. It's going to come up as LFTs, which is a misnomer, because when we draw LFTs, or liver function test, it's actually markers of hepatocellular injury or gallbladder disease. So most of the tests are going to be looking at elevations in markers for inflammation or damage, and then the pattern of those lab values tell us, hey, is this coming pre-liver? Is this happening in the liver? And we'll talk about what makes up the LFTs. But just keep in mind, LFTs don't really tell us much about how the liver is functioning. It tells us what signs of inflammation or damage that we're seeing and why we're seeing that. Typical panel there, the aminotransferases, ALT, AST, and we're going to talk about each of these as we get further in the slides, or further in the slide deck. Alkaline phosphatase, total protein, bilirubin, and albumin. So that's your typical LFTs. It'll be those 5. I would know what makes up a typical liver function test. And you have to know what's happening with these markers when we talk about trying to determine the etiology of liver disease. So we also have some other markers. Sometimes they'll be in your set that you're getting in whatever facility that you're at. If not, you'll have to order them separately. But the gamma-glutamyl transpeptidase, GGT, lactase dehydrogenase, LDH is the abbreviation that you'll see on your labs for that one. Prothrombin time, so we're looking at coagulation, right? And then platelets. Bless you. All right, so those are just 4 more that if they're not included in your panel for your facility or what you're ordering as whatever lab you're using for LFTs, those are further markers that we want to order to help us, give us those diagnostic clues as to what may be going on with our patient in liver or gallbladder or pancreas disease. Normal values. Anytime you take your boards or if you take a test here, when we start talking the LFTs, no one is going to memorize all those numbers and those ranges. So they'll be given to you normally, even when you take your PANTS or your research, you can click on it and a whole list of lab values drop down. So be vaguely familiar, but really the numbers aren't that important, to be honest. What's important when we start looking at LFTs is the pattern, right? Of those LFTs, are we getting a bigger rise with ALK phos compared to AST, ALT? Or is it the reverse? Are we getting a bigger rise or disproportionate elevation in AST and ALT and not ALK phos? And we'll get into each one of those in the upcoming slides as to what that exactly tells us. And then you can get your total bilirubin versus your direct. So we talked about the difference. Total bilirubin is all the bilirubin in your body, in your blood. And then when we talk about the conjugated, obviously we know that that's going to be liver or post-liver, right? Once it's conjugated and water soluble. And as I said, if we give you in here, or if you, when you get to your board certification tests or recertifications, you're going to be given those lab values. So you don't have to memorize them. What you need to know is the ratios. If we see abnormal values, what are the ratios? What's up? What's down? What's normal? So the patterns. So for hepatocellular, meaning it's happening in the cells of the liver is where we're having injury or damage, you're going to see a marked elevation in AST and ALT. So if you are having hepatocellular injury, or your patient is having hepatocellular injuries, it will be marked elevation in both AST and ALT. And there's a graphic there to show you. And that's in relation to alkaline phosphatase. So if you see AST and ALT markedly elevated, but you got your alk phos at around normal, then we're going to say, hey, this is probably going on inside the liver cells proper. Why is that? Well, when the liver cells are injured, they're going to basically leak AST and ALT into the bloodstream. ALT, more specific for liver. And the AST itself can be elevated by other causes like muscle injury, hemolysis, so red blood cell breakdown, but ALT is liver specific. It's primarily in the liver, not 100%, but ALT primarily in the liver, and then AST in the skeletal muscle and the red blood cells. That's why ALT, since it's primary in the liver, which has an L in it, ALT goes with liver. Primary in liver, so normally with hepatocellular or liver cell specific injury or compromised, then you're going to have the ALT be more specific because it's mostly found in the liver. But both will rise, as I said, with hepatocellular damage. What is transaminitis? Basically, AST and ALT are elevated. So if you see that term, patient, presents XYZ, labs reveal transaminitis. That means what? ALT and AST are elevated. And then if you have a normal alk phos, well, now we're looking at hepatocellular damage, so something to liver cell specific. A lot of times when we have these elevations in ALT and AST, it's just going to be otherwise asymptomatic patient. And now we're seeing these elevations and abnormal labs with the transaminases, and now we have to start figuring out what's going on, and the diagnosis is gigantic, right? The differentials. The etiologies are just so vast because we talked about all of the processes that our liver does for us in normal homeostasis. So then that's just a partial list. So we talk hundreds of functions. When we say when we have transaminitis, our differential starts off really, really broad. If our patient is presenting asymptomatically, hopefully we can have some other clues to lead us towards the right etiology, but often not. Patient feels fine, walking around, everything's good to go. We order some routine labs for their annual physical or something for another reason, and all of a sudden we have elevation, AST, ALT, transaminitis, and why. So we'll talk about how we differentiate that with the bullets there, or with the entries under the second bullet there. First, a great history. Right? thorough history, trying to figure out, is there anything in the patient's history that's leading to any kind of liver dysfunction, which has now caused AST and ALT elevation, so transaminitis. A good physical exam, where you remember that, where you're going in and you're trying to feel the liver during the exam, which you said you did during your sophomore and junior year, or both, when you're palpating for the liver border and trying to measure it and all that good stuff. So, and on our normal population, you really are not feeling the liver, right? It's still up underneath the rib cage. So, in these patients, though, if we got a liver disorder or an enlargement of the liver, now you'll actually palpate that liver border and have to start measuring it and saying, what is the amount of inflammation that's going on with the liver. Repeat the lab. You'll see often when you just have AST elevate or an ALT, so a transaminitis, a normal patient presentation, no real signs and symptoms, no great history, or no history to make you think, okay, this is what may be causing these elevations in AST and ALT. Just give it a while and repeat it, and make sure that it's not just a moment in time where it was elevated by, something in their diet, some new medication that they started, the amount of exercise that they're doing. Often when we have these elevations that are kind of unknown to us as to why, we'll repeat the labs and say, is this a pattern, right? And, worst case scenario, we have worsening of the transaminitis. Now we really have to figure out what's going on. Best case scenario, AST and ALT have normalized, and we'll just say, hey, 6 months, a year, maybe we'll repeat them again and make sure. But often repeating the lab is pretty much standard of care, unless it's blatantly obvious that there's something else going on based on history and physical. Get a hepatitis panel. We'll have an entire lecture on hepatitis. So if ALT and AST are elevated, we can get the hepatitis panel to see if there's an acute inflammatory reaction or infection going on with liver proper due to hepatitis A, B, C, D, or E. And we'll get into what all of those are. But if you think that this is significant transaminitis, now do a hepatitis panel. We'd also do a hepatic ultrasound to see if we see any enlargement or swelling or anything going on with the liver. And if we repeat the labs, they come back, we can't really figure it out. We send them out for an ultrasound, still can't figure out what's going on. Time to probably phone a friend, right? Reach out to GI and say, can you help me with this patient? Can you evaluate and treat my patient with transaminitis of unknown origin? So one key that you should know, it's going to be on your boards, it's going to be every time anyone talks about liver, basically, or transaminitis. If you have a 2-to-1 elevation of AST to ALT, often that's going to be alcohol. And then you also ordered that other marker, GGT. So if you have that 2-to-1 ratio, or greater than 2-to-1 ratio, transaminitis, AST to ALT, get the GGT, and if it's elevated as well, you're looking at alcohol, more than likely. And is your patient going to be truthful when you're asking them how much alcohol they're consuming on a daily basis, weekly basis? Probably not, right? Probably not, but they may. If they're having bad enough symptoms, that's usually when they come clean, right? But otherwise, no, 1 to 2, a night, never more than 3, sure. And then the AST to ALT ratios way out of whack. The GGT is huge, so I would know that ratio, and what leads us to think that it's alcohol-related transaminitis based on the ratio, and also very, very pathognomonic if the GGT is also up. So this is the biochemical functions of AST and ALT. It's a lot going on there. What I need you to know from this, and you can read through it, it's talking about basically the enzymatic catalyzation of AST and ALT, but basically you just need to understand why that ratio changes to 2:1, AST to ALT, and then it means alcohol, especially in light of GGT. And it talks about the pyridoxal 5-phosphate deficiency, and because that's inhibited with ALT, AST goes up higher. I'm not going to test you on the background and the biochemical. If that was important, you would have had it in biochem. So GGT, like I said, another useful lab. Often will come with your LFTs now, but if not, you need to get it if you're worried about transaminitis. So GGT is present in the liver cells and the biliary epithelial cells, the renal tubules and pancreas and intestine. Very useful in identifying hepatic or liver proper sources of elevated alkaline phosphatase. And the next coming up slides will talk alk phos, but if alk phos is up, alkaline phosphatase is in a lot of locations too. So if you're trying to determine, is this liver, when you have an elevated alk phos, you can look at GGT. And if GGT is elevated, it's liver, right? That alk phos is going up because of liver damage. Because GGT is very specific, sensitive. So it's going to, if it goes up, then you're looking at liver causes. GGT can be observed in a variety of non-hepatic diseases, such as COPD and renal failure as well. Alk phos is elevated, check GGT, just what we said on the last slide. So a whole spectrum, any of the liver diseases, regardless of the cause, may be responsible for altered GGT. Like I said, it's sensitive, but not specific. And because it lacks specificity, but a very sensitive test for liver, if ALP is up, alk phos, which is liver, bone, pregnancy, medications can increase ALP. So a lot of different things for ALP. So then get your GGT, go, okay, this is liver. Because ALP was elevated and now GGT is also elevated. And then once again, that ratio, AST to ALT and GGT, think booze. Just another quick review as we move in to gallbladder and bile duct or post-hepatic causes of increased bilirubin. Like I said, if you're not familiar, need a refresher, please do so. So the patterns for the liver function test. We talked hepatocellular, like when we have specific for liver patterns, what that looked like. And now we're going to look at cholestatic patterns. So with cholestatic patterns, so we start thinking, oh, something's going on between the liver and the gallbladder. Now your alkaline phosphatase, or ALP, is elevated disproportionately to the AST and ALT. Because if it was liver, is it AST and ALT that's elevated, or ALP? If it's liver, transaminitis, AST and ALT are going to be elevated, alk phos really no change, right? Or mildly elevation. opposite now we call when we say a cholestatic pattern. Alk phos is elevated disproportionately to AST and ALT. Basically, when we pull those LFTs, you're going to see that the alk phos is disproportionately elevated compared to any changes we see with AST and ALT. So what are we looking at? Of some type of biliary obstruction or inflammation of the gallbladder. So either bile's not getting out of the liver into the gallbladder, or we have some blockage in getting the bile through the gallbladder and out to the intestines. So why? Is because bile, alkaline phos is produced in bile duct epithelial cells, right? So any obstruction or blockage of the flow of bile is going to cause ALP in production to increase. So an obstruction or cholestasis. So cholestasis, basically, you're not getting flow of the bile from liver to gallbladder because alk phos is produced by the bile duct cells of the epithelium. When you're not getting the bile flowing, then alk phos is going to rise. Like I said, cholestasis, reduced blood flow of bile from the liver. ALP is an enzyme, transports metabolites across cell membranes. Most common causes of ALP being elevated is going to be liver and bone disease. And then that last bullet is what I explained of why ALP increases. It's because it's on the surface of the bile duct epithelium, and if you get an impairment of bile flow, then it's going to enhance synthesis and release of ALP from the bile duct epithelium. And so you'll get the bile salts increasing, accumulating as it's increasing release from the cell surfaces. So we measure it and go, okay, something's going on, some type of obstruction, physical, like a stone, or a stricture, something closing off the path of the bile, or for some reason, could be genetic as well. We have an issue with the bile flowing from liver to gallbladder. So isolated alk phos elevation, when it's up, you need to confirm, is it from the liver? So what do you get? Once again, just like we discussed earlier, get your GGT. Sensitive but not specific. Also draw the 5-nucleotidase. It's basically a liver enzyme that it helps with the metabolism of nucleotides. I don't need you to know all that. I need you to know that ALP is isolated, elevated. You're going to confirm that it's come from the liver by getting a GGT and the 5-nucleotidase enzyme. So get that level. Another piece of the picture that you can order with that blood draw that you're getting to send off for the LFTs. So when it comes back and alk phos is elevated on your routine LFTs, and now it's time to get the GGT and it's elevated, yep, liver, the 5-nucleotidase level is elevated, yep, this is liver. If GGT and the 5-nucleotidase are good to go, but alk phos is up, start thinking some type of bone disease. So alk phos isolated up, GGT good to go, 5-nucleotidase good to go, start thinking that that alk phos lab is elevated due to bone disease. And that's another lecture for another ology. All right, jaundice. Basically, yellow discoloration of the skin and sclera. Why is elevated bilirubin? We talked earlier in the lecture what color it is, right? Yellow, olive green. Clinically visible when bilirubin exceeds 2 milligrams per deciliter. That's an important number. It's on the next slide. You're going to see jaundice when you have bilirubin above 2 mg per deciliter. You also hear it referred to as icterus, same thing, jaundice icterus. Normally the whites of the eyes, once it hits that 2 milligram per deciliter threshold, that's going to be the first sign. It's going to be yellowing or jaundice of the sclera of the eye. I think we have a picture coming up too. And that's because the bilirubin is going to accumulate in the conjunctiva. Clinically apparent above that 2 mg per deciliter, and appears first in the conjunctiva. And when boards are testing it, often you'll see patient has scleral icterus, so yellowing of the eye. There's just a side by side, the same person, normal, and then way more than 2 milligrams per deciliter of bilirubin. Obvious yellowing of the skin. His eyes are blacked out for privacy, but obviously you would see that scleral icterus if you didn't have the black bars over the eyes. And there's a picture of the scleral icterus. When you see it, you'll know it. It'll be very striking to you, and you will go, oh, this is not right. And then it's time to start getting some labs, like we just discussed, trying to hunt down the cause of this scleral icterus, jaundice of the eye. So we characterize jaundice just kind of like we were talking about bilirubin earlier, prehepatic jaundice. So that's coming usually for some type of hemolysis, hemolytic. And then we have hepatic causes of jaundice, which are liver, direct, hepatocellular. It's being caused by something going on with the liver proper, liver cells. And then posthepatic, which is normally obstructive. Something going on with that flow between the bilirubin and the bile, the liver and the gallbladder. Between that conjugation of the bilirubin as it moves into the cystic duct. So, unconjugated hyperbilirubinemia, conjugated hyperbilirubinemia. No difference than when we were talking about bilirubin, whether it was unconjugated or conjugated. Now we're just saying that it's hyperbilirubinemia caused by either prehepatic, hepatic, or posthepatic. Still the same terminology. Is it above 2 milligrams per deciliter due to a pre-liver issue, a liver-specific, or an obstructive cause post-hepatic? Just an overview of what we've already discussed at length. The conjugation of bilirubin. In the blood, you're going to have that unconjugated bilirubin from the red blood cell breakdown or heme metabolism, going to join up with albumin and protein, and then that unconjugated is going to go into the liver cells, moving down from the blood into the middle of the slide, into the liver, where it gets conjugated, and then that conjugated bilirubin goes into the biliary system, through the gallbladder, and then it's going to go into the small intestine, as we mentioned. Bacteria is going to do its thing, start breaking it down, and then we're going to have that urobilinogen. This is just an overview of everything we talked about on the slide as far as the conjugation of bilirubin and the steps, those 4 steps. So plasma elevation of predominantly unconjugated remember we also call it indirect, can be due to overproduction of it, i.e. we're making too much bilirubin, or your patient is, or for some reason the liver can't uptake that unconjugated bilirubin. So now, if the liver can't uptake it, you got the unconjugated fat-soluble bilirubin remaining in the bloodstream, right? So obviously, you're going to get more than 2 milligrams per deciliter if we're not able to conjugate that bilirubin, go through those steps, and then get it excreted out into the urine or feces. So if it's the third possibility for the unconjugated indirect bilirubin that's causing jaundice and it's elevated is an abnormality of the process of bilirubin conjugation proper. So something's keeping that reaction that we said happens in the liver from performing the steps necessary to conjugate the rubin in the liver. Something in that enzymatic pathway. So causes, unconjugated, so increased bilirubin production. So we're making a lot of it. Well, we said, how do we make it? It happens from red blood cell breakdown. So if you have a hemolytic anemia, what are you doing? Breaking down more blood cells. Therefore, your unconjugated pre-liver bilirubin is going to increase. And once it goes over that 2 milligrams per deciliter, now we can start seeing jaundice. Hemolytic reactions, hematomas, pulmonary infarctions, all causes of pre-liver unconjugated hyperbilirubinemia. And then when we talk about the impaired uptake and storage, we can have a post hepatitis hyperbilirubinemia, i.e. there's some infection of the liver. There's a couple of syndromes here, the Gilbert and the Crigler-Najjar syndrome. So both of those benign genetic liver disorders, but in the case of Gilbert syndrome, the liver just processes the bilirubin slower due to that benign genetic liver issue. And then the Crigler-Najjar syndrome, another genetic liver issue, and the process of that disease means the liver cannot break down bilirubin. And your drug reactions are in the impaired bilirubin uptake and storage category as well. So plasma elevation of unconjugated and conjugated. It's a misnomer, but it's often described as conjugated hyperbilirubinemia. But if you see it, if you see conjugated hyperbilirubinemia, know that it's actually both unconjugated and conjugated bilirubin that's increased. When you have the conjugated hyperbilirubinemia, a lot of times that's cellular liver disease, impaired canicular excretion of bilirubin. What is the canicular excretion of bilirubin? Anybody know?
Can't get out of the duct.
It's basically the hepatocytes can't secrete bile, right? So canicular excretion itself is a secretion of the bile by the hepatocytes. If that process is impaired, we can get the conjugated hyperbilirubinemia. And a biliary obstruction proper can give us both unconjugated and conjugated, but we categorize that as conjugated hyperbilirubinemia, even though it's a misnomer because both unconjugated and conjugated are actually elevated. So conjugated hyperbilirubinemia. So too much bilirubin, and it's already been conjugated. So that can be hepatocellular disease. Once again, this can be hepatitis, cirrhosis. We're going to get into each of those. So an infection of the liver, or cirrhosis, like damage to the liver, chronic damage to the liver. Those can both lead to increase in the conjugated hyperbilirubinemia leading to jaundice, or biliary obstruction, which is cholelithiasis. Anybody know what that is? Hopefully, it's a gallstone, right? Gallstone and a common bile duct. Biliary atresia, basically, it's congenital. You'll see this in kids a lot. The bile ducts are affected. They're either absent or they're blocked. So that's what biliary atresia is. Basically, bile can't flow because the bile ducts are not there, partially there, or they're blocked. But that can also cause conjugated hyperbilirubinemia and cancer, which is our next to last lecture this week. And then a whole slew of hereditary cholestatic syndromes, a whole bunch of diseases that affect the gallbladder, which is 2 or 3 lectures from now. So with that, we'll go ahead and stop, take a 10-minute, and come back and finish up.
Yeah, that's probably like if you have like push
I have a question for the Gastro. It says signs of posterior compartment syndrome. That's from the injuries, it's not.
oh yeah, that's if they so that's an indication. Yeah. That's saying like you would so saying that you have a large couple defects in the capsule or because of the injury that caused the tear, now you're starting to go to the heart which we already got off the flag.
So that's why
So if it was on the next stage for like adverse treatment, then I would say
probably.
actually didn't feel tired at all until like midday this morning when I was climbing here. I was so tired.
Okay. ALP, alkaline phosphatase. And AST and M came too a little bit. Bone is really when you think of it, but it is in a lot of other places. But we're obviously, in our case, we're saying we grew it because we're liver, right? So we did a liver function. Okay.
So upside down.
Right, so now we go to GGT and I would do both, yeah. And if those two are because GGT
Oh, wow. And I even asked her, I'm like, hey, she takes sleep. She said, yeah. And, but she had been waking up for some reason. I don't know. I'm scared.
Woke up.
But then she but it was good. It was good. Holy crap. Higher March. Like a big time.
Yeah, we usually see outside.
Will not eat anything. Then yesterday he ate like 60 minutes and the whole thing fried. Like all of his food
Correct.
the entire thing
Is that how it's going?
you just gonna starve yourself until you're so hungry.
In relation
Also from that, in my effort to reset my thing,
Yep.
as well still do not have an app. So therefore I cannot download any of the old apps that I used to. Big. Whoa.
Hell yeah, dude. If we can shoot it up, changes your hormones. It's the best. It's like fine altering percent. Make this one. Oh, yeah, true. Yeah, I don't start getting paid until the day I start selling. I work the day before. That was just your last day. Second quarter. Also,
All right, we're ready to start again. We'll finish up with liver one. I think we got 2 or 3 more lectures on liver. But like I said, we hepatitis, liver cancer. So we'll finish up with jaundice and then move into the next topic. So unconjugated jaundice findings, usually mild. Normally the stool and the urine are going to be normal color, which these are going to be the differentiators between when we start talking about conjugated jaundice or jaundice from conjugated bilirubin. So for jaundice from unconjugated bilirubin, usually mild, not like the gentleman we saw in the picture. And the stool and urine are going to be normal because there will be no bilirubin in the urine. If it's a hemolytic disorder, we expect to see something going on with the spleen. So splenomegaly, some enlargement of the spleen. And that will be your unconjugated or your prehepatic. indirect causes of jaundice. So know the differentiators when we talk these next couple of slides from this one. So for conjugated hepatocellular, liver cells proper, those clinical findings, you're going to have some systemic signs and symptoms starting to show up because you have a hepatocellular proper cause of the jaundice. So malaise, anorexia, so tired, weak, not feeling hungry. Patients can have a low-grade fever, could have some right upper quadrant pain. We all know where the liver sits, and we're talking liver-specific cellular injury that's leading us to having increased conjugated bilirubin over 2 mg per deciliter, causing jaundice. Now we'll have dark urine. Amenorrhea can be present. A palpable enlarged liver that's tender. Spider telangiectasis. Palmar erythema. Ascites, and even some gynecomastia. So if you're seeing any of those signs and symptoms, and when your labs come back on your jaundice patient and it's more conjugated than unconjugated, then we're looking at liver proper with those signs and symptoms being a possibility. Very different from our patient presentation on the last slide of our unconjugated causes for jaundice. If we have cholestatic syndromes, cholestatic meaning what? Okay, yeah, the flow of the bile, right? Well, most of the time it's gallbladder, but something's happening with the flow of the bile. Most of the time gallbladder. But if it's cholestatic findings for increased bilirubin of the conjugated type, jaundice with pruritus and light colored stools, I would know this slide. Boards test it all the time. Cholestatic syndromes, patient presentation with jaundice. It's conjugated, they have pruritus and light colored stools, which is different from the other two slides we just discussed. So biliary obstruction proper, jaundice, right upper quadrant pain, weight loss, which could be carcinoma, pruritus, dark urine, and when we say light colored stools, that's acolic. So note this in the last slide. This more specific for biliary obstruction. The other one for just the flow of bile. This one's specific for biliary obstruction. How do we work them up? Well, CBC, CMP, UA. We can get hepatic ultrasound if we're worried about it being, well, either liver or gallbladder or bile duct. We can get an ultrasound to see if we can visualize what's going on. ERCP is a special test we can do to look at the bile ducts if we think there's obstruction. And we'll go in on the next slide a little bit for ERCP. So we can do ultrasound, or if we're expecting obstruction, it's patients presenting with the signs and symptoms on the last slide, we suspect obstructive cause, then we'll go to order ERCP. And we'll discuss that here. So the endoscopic retrograde cholangian pancreatography. One time I say it, that's it. It's ERCP from here on out. So it's an endoscopic technique where we go, it's an upper endoscope, right? So we're going down to the mouth. And just like other endoscopies, We can diagnose using this evaluation, but we can also treat if there is an obstruction. So basically, they guide the endoscope into the duodenum, and now the instruments can be passed into the bile and pancreatic ducts. So if you suspect biliary obstruction based on signs and symptoms in a jaundiced patient, we can order the ERCP, and the GI doc is going to go in through the mouth, down into the small intestine, and then get into the bile and pancreatic ducts and see if there's an obstruction that they can unobstruct while in there. Also into the gallbladder proper. I didn't say that. So bile ducts, pancreatic ducts, and gallbladder proper. Just a visualization of the ERCP. And I would know when to order it, which is when to suspect the obstructional cause of your jaundice, and as we mentioned on the slides, with the signs, symptoms, characteristics, and if we think it's obstructive, then what test? ERCP. So treatment for jaundice, well, we figure out first what's going on, and then we treat the underlying cause. Usually, it will not be us as primary care PAs. Maybe you, if you're working in a GI specialty clinic, but normally with jaundice, we're not doing all this workup. We're certainly not doing an ERCP unless we're working in radiology or GI. And these patients are going to be, after you get your lab testing done, you've started narrowing it down, what's going on, your jaundice patients. We need to phone a friend on and get some GI specialty folks involved with that discussion. Okay, move on. And here's a nice chart, pre, post, and hepatic proper causes of jaundice, but this is basically putting all the stuff we said on the other slides together, if you need it for the visual learners. Talks about the urine color, and then whether things are positive or negative, or there or not there, seen with pre or hepatic proper or post-hepatic causes of jaundice. And here's one of the cartoon slides, same deal, just showing you the types of jaundice, whether it be before conjugation, after it's conjugated in the liver, or if it's already conjugated in the liver and moving into the gallbladder or the intestines. Okay, final topic on today's lecture for liver 1, we'll call it, is toxic liver injury. Basically, some substance damaging the liver cells, the hepatocytes. Your big players are there: acetaminophen, big one, statins, NSAIDs, antibiotics, some over-the-counter drugs, and some herbal supplements. The acetaminophen is a must-know. You have to know toxic liver injury from acetaminophen. Some substances can potentiate the liver injury or hepatocellular toxicity damage when they're on board at the same time, right? Tylenol and alcohol together, bad juju for toxic liver injury. And we'll discuss Tylenol specifically. So basically, toxic liver disease, the toxicity is classified by what's causing it. So the pathogenesis and the pattern of the injury. Once again, what are we talking? Direct hepatotoxicity. This is predictable pattern or pathogenesis. So it's dose related. So we know if we take this hepatotoxic drug, chemical, you name it, that is predictable as to, once we get to certain levels circulating in our bloodstream, as to what the toxicity pattern is gonna look like. So we can predict, based on the dose, changes and inflammation or damage to the liver cells proper. We can also predict, based on exposure, when we expect to see signs and symptoms. Is it 5 minutes after the patient ingested X, Y, or Z? Is it 10 minutes? Is it an hour? Is it 6 hours? We can predict the timing of between ingestion or exposure to when we start seeing signs and symptoms and side effects. And universal susceptibility. If it's direct hepatotoxicity and it's predictable, universal susceptibility means we expect this to happen in most patients. Whereas one of your patients may have a genetic disorder that predisposes them to some type of hepatocellular damage. If there's something going on, that's a one-off. If Tylenol is the culprit, then universal susceptibility is we expect most normal patients to have these signs and symptoms and this normal projection of toxicity in most people. So it's kind of universal. We think you have X amount of Tylenol, for example, then at this milligrams per deciliter, however long after you took it, we can predict what's going to be going on with the liver. So the difference, the contra to that, is an idiosyncratic reaction. That means we can't predict what's going to happen based on how much you took it, when you took it, how long after you took it, as far as what we're going to see going on with the liver proper. So we have to understand the pathogenesis and the pattern. Is it predictable? And those are 3 bullets that make the drugs and the toxins that we mentioned on the slide before. That's what we can say, that these we know are predictable based on what they will cause, the damage they'll cause in most people in a certain amount of time based on how much they took. And in general, universally, it's going to affect everyone the same way. Maybe difference in age or weight, but in general, we know what's happening with this drug or whatever we're ingesting that can cause toxic liver injury. Versus idiosyncratic, we don't know. Could be anywhere. You could be fine, you could be dead in 5 minutes. Like, you can't predict what's going to happen. Acetaminophen, leading cause of acute liver failure. One of the most dangerous drugs that people go and buy anywhere, anytime, and take how much ever they want. But toxicity from acetaminophen, leading cause of acute liver failure. And then you throw alcohol on top of it, because when folks are drinking all the time and they're waking up with their headache, what are they taking the next morning? Either NSAIDs or some Tylenol usually. And then when you start to get that Tylenol chronically in your system combined with the ethyl alcohol, as I mentioned on the earlier slide, now we're inching towards that liver injury and possible failure. So recognizing acetaminophen overdose or acetaminophen toxicity, important. Because it can lead to fulminant hepatitis and painful death syndrome. Tylenol may kill more than just pain. There's a nomogram which basically shows us all of the things when we said predictability. There's a chart specifically, a nomogram called the Rumack-Matthew nomogram, which basically looks at the dosage and the predictability of the progression of injury based on dose-related patterns. So all those bullets that we talked about for predictability for medications or different chemicals that can injure the liver, there's a specific one for Tylenol as far as a predictable dose-related pattern, progression of energy, of the injury. You will not be tested on it other than to be able to recognize what it is by name, the Rumack Matthew nomogram. I'm not going to expect you to make any predictions off of it. There's also antidote. You need to know that. Tylenol overdose treated with N-acetylcysteine. Should be a review. You guys should have already had that last semester, right? Or this semester, or both. But N-acetylcysteine antidote for Tylenol toxicity. There's a picture of it. As I said, it's just a predictable dose-related curve based on what we'll see as far as when we need to treat the patient or give them that N-acetylcysteine. Basically, if it's up over the right there, if it's up over the dark line, time to get some N-acetylcysteine on board. And you can see what the X and the Y axis are measuring to help you make that decision. So, once again, the toxicity of toxic liver injury classified by what's causing it and the pattern. So, hepatocellular injury, hepatitis, right? An infection of the liver can cause toxicity. Cholestatic injury, so can be non-inflammatory. We already discussed that with cholestasis is basically that movement of the bile. So if there's an inhibition of the transport system, or it can be inflammatory cause of toxicity, i.e. inflammation of the gallbladder proper, cholangitis, or it can be mixed. So when you have that liver injury, you can start looking at the specific pattern as to what can cause it, i.e. liver itself, liver cells can be from infection of the liver, cholestatic injury, non-inflammatory will be something impeding the movement of the bile, inflammatory being inflammatory process, usually cholangitis, so an inflammation of the gallbladder, which we'll hit in depth in a future lecture, or a mixed injury, different things going on. Treatment, well, if it's drug caused, stop the drug, right? If you're getting toxic liver injury from one of those medications that I mentioned about 5 slides ago, a long list, 8 to 10 things, if one of those are on board and we suspect that that's the culprit of the etiology of our toxic liver injury, then we need to stop that medication. Severity will determine inpatient versus outpatient. You're going to want a GI specialist or a liver specialist involved, right? GI subspecialty, if it's liver, the super experts in just liver, so a GI or gastroenterologist who's focused only on liver, if it's liver specific. And how do we monitor if they're getting better? Well, those labs are elevated. We start getting those on a regular basis and monitoring to see those transaminases moving down, right? We want to see response to treatment or removal or removal of the offending agent. So we look at LFTs for normalization of the values. If you have toxic liver, definitely phone a friend. You're not treating this on your own. And that brings us to the memory jog, which I'll let you go through on your own. So all the lectures with the memory jog should be posted now. We're good on check on learnings posted up to the one I just did. So I'll post that one this evening, and then we will meet again tomorrow for